Hi, everyone. Thanks for being here. Going to get started. My name is Devora Aharon. I'm one of the attending physicians at RMA of New York. I'm located at our Eastside location on Madison Avenue. I'm also on faculty at Mount Sinai, which we are affiliated with. And so today I'm going to be talking about IUI and IVF and some of the differences and things to think about as you might be thinking about fertility treatment. So first of all, what are these acronyms, right? There's a lot of letters, there's a lot of I's. So IUI stands for intrauterine insemination, and IVF stands for in vitro fertilization. And we're going to talk in more detail about what these are, but you may be trying to get pregnant. Maybe you've gone for a consultation and you've been told about IUI and IVF and you're not sure which is the right option for you. Or maybe you haven't had a consultation yet. Maybe you just started trying or you're thinking about trying and you've heard about these treatment options. So I'm going to talk about, what these are and what are the things to consider as you think about which strategy might be right for you. So first, we'll talk a little bit about reproductive biology, what happens and what needs to happen in order to get pregnant, what kind of testing we can do to check fertility and if there's any issues. We'll talk a little bit about aging as it impacts fertility. And then we'll go into more detail about what is IUI and IVF and the advantages of each one. And now off the bat, I'm not here to say that one is always better than the other, right? There's advantages to both of them, and people definitely have success with both treatments. There's going to be a lot of factors to consider. A lot of it is very individual, but we're going to talk about some of the things that you might want to think about when thinking about one versus the other and deciding the right approach for you. Now, there is a Q&A. Please feel free to put questions in there, and we'll see if we can get to some questions in the middle, or at the end, I'll definitely answer all questions. So let's talk about what normally happens. What needs to happen in order for pregnancy to happen? So here in this diagram, you can see the uterus. This is the cervix, the vagina, the fallopian tubes, and the ovaries. So the eggs are contained within the ovaries, and they're contained in these little pockets called follicles. At the beginning of a menstrual cycle, the ovary recruits a certain number of eggs into fluid-filled follicles. We can see these follicles on ultrasound. We're going to look at some pictures of that later. And these fluid-filled follicles that we can see contain the eggs that have the ability to grow and mature and ovulate in that cycle. Now, in a natural cycle, one follicle is designated as the dominant follicle. This follicle grows. As it grows, the egg inside of it matures. That egg then ovulates. It's released into the pelvis. The tube picks up the egg, and then sperm comes up through the vagina, cervix, uterus, comes out through the tubes, finds the egg and fertilizes the egg, and then the embryo travels into the uterus as it's growing and implants into the uterus, and the pregnancy grows in the uterus. So there's 4 basic things that we need in order to get pregnant that we can do testing for: the eggs, the uterus, the fallopian tubes, and the sperm. So with the eggs, we want to make sure that someone is ovulating on a regular basis, once a month, releasing an egg that has the ability to fertilize and result in a pregnancy. We want to make sure that the egg quality is good and that there is a sufficient number of eggs. With the uterus, we want to check for any structural abnormalities that might impact the ability of an embryo to implant. We want to check the fallopian tubes to make sure that they're open and that the structure of the tubes is normal, and that there's no scarring or abnormalities. And then we want to check the sperm using a semen analysis, where we look at the number of sperm, how they're moving, the shape of the sperm, and a few different factors. So I see that there's a question about success rates. We definitely will be talking about that. Okay, so it's important to keep in mind that human reproduction is actually quite inefficient. When you take all couples, heterosexual couples trying to conceive, there's only about a 20% chance of success per month. And as you get older, this goes down. So maybe even like 10 to 15%, depending on age. By 6 months, about 60% of couples will have conceived. By 12 months, 80% of couples will have conceived, and the 15% that haven't are considered to have infertility or subfertility. And so it's recommended to get testing, consider treatment. In women who are older than 35, it's recommended to consider treatment starting, earlier, really after 6 months or so, because of the impacts of aging. And now these are not hard and fast rules. We definitely do think about doing treatment, earlier than these cutoffs, but that's sort of the reasoning behind those 6 months and 12 months that you might hear about. So the reason for this inefficiency is mostly due to the egg, and it has to do with the number and also the quality of the eggs. So women are born with all the eggs we're ever going to have. As we get older, they're constantly declining in number and also in quality. Now, we actually have the most eggs ever when we're in utero as a fetus, and that's about 6 to 7 million eggs. By the time we're born, it's already declined to about 1 to 2 million eggs. By puberty, it's gone down to about 400,000. And then that continues to decline until we hit menopause, when there's basically no eggs left. You ovulate about 400 to 500 eggs over the course of your life. So there's a constant decline in eggs, even outside of what you're ovulating. At the same time, the quality of the eggs is also declining. And it's actually the egg quality that's the most important factor in determining likelihood of getting pregnant when you're trying. So when we talk about egg quality, what we're mostly thinking about is the chromosomal content of the egg. Chromosomes are like packages of genetic material. You need to have the right number of chromosomes or the right amount of genetic material in order to create a healthy pregnancy. So every cell in our bodies has 46 chromosomes. Eggs and sperm each have 23, it's half of that. And when the egg that ovulates is chromosomally abnormal, it usually does not result in pregnancy. If it does, it will typically end in a miscarriage, and this is the reason for 80% of miscarriages. Or it can result in a baby that has Down syndrome or another disorder that's due to an abnormal number of chromosomes, but it basically will not result in a healthy baby. And so really the most important factor in determining likelihood of getting pregnant is whether the egg and the resulting embryo is chromosomally abnormal. Now, as women get into the late 30s and 40s, the proportion of eggs that are abnormal rises. So this data is showing the percent of embryos which are aneuploid, which means chromosomally abnormal, according to female age. So at baseline, it's maybe like 20 to 30% abnormal. It's never zero, and this is why it can be hard to get pregnant at any age. Miscarriages happen at any age. Past age 35, though, the proportion that are abnormal rises. Now, initially, it sort of rises sort of gradually. By 38, 39, it's about 50% abnormal. By the time you're in your early 40s, the majority of the eggs are abnormal, and each year it really jumps 60, 70, 80%. Past age 44, 45, essentially all the eggs are abnormal, and it becomes very difficult to get pregnant, at these ages. So this is important to keep in mind when we're thinking about age, as you're thinking about whether to do IUI or IVF, and which can kind of get you to pregnancy faster and potentially give you a potential for pregnancy when you're older. So one thing to think about is if you want to have multiple kids, how old are you going to be by the time you get to baby number 2 or baby number 3? The reason why this is important is because the uterus actually doesn't really age in its ability to carry a pregnancy. We can create a pregnancy at almost any age, past 44, 45, even actually past menopause, by using a chromosomally normal embryo that was frozen when you were younger and have a very high chance of success. So again, this is going to come into play when we talk about different factors to think about when you're thinking about your treatment. So, again, likelihood of success is mainly due to the age of the egg. Okay, so now what are these treatments? What is IUI? So again, intrauterine insemination, it's basically giving a boost to the sperm. So how does it work? The male partner gives a sperm sample, or sperm donor, let's say, gives a sperm sample. The sperm is washed and prepared so that we get a more concentrated sample of the best moving sperm. And then we do a procedure where the sperm is injected into the uterine cavity. And so what does this procedure look like? It's kind of like getting a pap smear. It's done in a regular exam room. And we use a speculum to look at the cervix, put a very soft catheter into the cervix, through the cervix into the uterus. It's not painful. There's maybe a little bit of cramping, and then we inject the sample at the top of the uterus. And then 2 weeks later, you hopefully have a positive pregnancy test. If not, you'd get a period and we'd start over. So we are, preparing the sperm, injecting the sperm into the uterus. Everything else is happening internally, right? So we're not controlling or changing, many aspects of what's going on. So if there are other underlying issues, it's not really addressing those other issues per se. With IUI, we often will give medication for ovulation induction or superovulation. And the medications we typically use are Clomid or letrozole. These are oral medications. They're pills that you take typically for 5 days at a time. So if someone is anovulatory, meaning they don't ovulate, they're not getting regular periods, they're not releasing an egg on a regular basis, so they're not having those opportunities to get pregnant, we would give one of these medications to induce ovulation, cause them to ovulate. So the goal is to get them to grow one follicle at a time, really, that's going to ovulate and release a mature egg. If someone is ovulating once a month, they already have that egg that they're releasing. So what we're trying to do is actually to get them to ovulate more than one egg at a time. And so on ultrasound, you can see more than one follicle growing by using these medications to increase the chance of releasing a healthy egg that can be fertilized and create a healthy pregnancy. And so with this, we will track ovulation and time the IUI around ovulation. So what does the process look like? We always start with a menstrual cycle. You call us when you get day 1 of full flow. On day 2 or 3 of your cycle, you come in and we do baseline labs. If you're doing medication, you take the meds typically from day 3 to 7, could be from day 5 to 9. And then you come back usually around day 11 or 12 of the cycle. We do an ultrasound to monitor follicle growth to see if there's a follicle growing or more than one. Based on the size of the follicle, we can see if it looks like it has a mature egg and it's ready to ovulate. If so, we give a trigger shot and that causes you to ovulate the next day. And so we do the IUI about 1 to 2 days after the trigger shot. Okay, just looking through some of the questions. Okay, so we'll get to some of these later. These are some more sort of individual questions. Okay, so what is IVF? So again, IVF is in vitro fertilization. Now, the goal with IVF is really to make multiple embryos and then find the best embryo for now and potentially for the future also, and be able to save those embryos and have a very high chance of pregnancy with each embryo transfer. So the idea of IVF is that we're stimulating multiple follicles to grow from both ovaries. We do an egg retrieval to extract the eggs from the ovaries, and then in the lab, we combine the eggs and the sperm, and we grow embryos. These embryos can then be biopsied for pre-implantation genetic testing, or PGT, and we look for chromosome abnormalities, so we know whether the embryo is chromosomally abnormal and basically is not going to result in a healthy pregnancy, or chromosomally normal and has a very high chance of resulting in a healthy pregnancy. We can also look for specific gene disorders when we test the embryo, if someone is known to be a carrier for something that they can potentially pass on to their children. And then we do an embryo transfer where we take one embryo at a time usually and place it back into the uterine cavity to create a pregnancy. So these are some images of fertilization and embryo development. So this is a mature egg being injected with sperm in the lab. And then we grow the embryos out in the lab. We grow them till about 5 or 6 days of embryo growth. This is the blastocyst stage. This is the stage when embryos typically implant into the uterus. At this stage, the embryo is 1 to 200 cells, and it has a component that you can see here called the inner cell mass that's going to become the baby, and an outer component called the trophectoderm that's going to become the placenta. We can take a biopsy of a few cells from the edge of the embryo, from the part that's going to become the placenta, and this has been found to be safe for the embryo. So we take the biopsy, then we freeze the embryo stays frozen, the biopsy goes for testing, and we test to see if the embryo is chromosomally normal, and it also for any specific genetic abnormalities that we're looking for. What does the process look like for you? So there's sort of, 2 parts. One is the process to make the embryos and then the process to transfer the embryo. So for the first part, we use injection gonadotropins. Gonadotropin hormones are hormones that are typically made by the pituitary gland in your brain to stimulate the ovaries to grow one follicle at a time. And we're giving these hormones in higher doses in injection form to try to get multiple follicles to grow from both ovaries. So it's hormones that your body knows. We're not giving, kind of new or different hormones. And so we start typically on day 2 or day 3 of your cycle. We also can use a birth control pill for scheduling. You come in for baseline blood work and ultrasound. You do injections of these medications. It's usually 2 to 3 injections per day for about 7 to 10 days. Then you come in every 1 to 3 days for blood work and ultrasound during morning monitoring hours. We're looking to see how the follicles are growing and your hormone levels are responding. Once things look ready, we give a trigger shot, and that triggers final maturation of the egg. So the eggs are basically preparing to ovulate. But before you ovulate on your own, we do the egg retrieval. And that's a procedure that's typically done under anesthesia. It takes about 10 minutes. We use a vaginal ultrasound with a small needle that goes along the ultrasound to extract the eggs vaginally. And then, as we saw in those images, the eggs are combined with sperm, and we make embryos in the lab, and we can test the embryos. We can transfer an embryo fresh, or the embryos can be frozen if they're going to be tested. So for frozen embryos, we separately do an embryo transfer cycle. So with a period, we do baseline blood work and ultrasound. You take estrogen pills for about 1 to 2 weeks. Then we do an ultrasound to check the lining of the uterus to see if it looks ready for an embryo transfer. And then if the lining looks ready, we start injections of progesterone, and the embryo transfer is typically 5 days later. Then we monitor the pregnancy with ultrasound and blood work about once a week till about 9 weeks of pregnancy, and the estrogen and progesterone injections continue till about 9 weeks. So that's kind of an overview of the process. This definitely can change or look a little different depending on someone's individual circumstance, but this is, sort of generally what it looks like. So, I've been talking about follicles and stimulating the follicles. So one thing that is important to, to discuss is that the fertility treatments that we use mainly work by increasing the number of eggs that are available to us in one cycle. So, we talked about how at the beginning of the cycle, the ovaries recruit a certain number of eggs into fluid-filled follicles. And in an unstimulated cycle, one follicle will ovulate. The other follicles that were recruited that cycle will degenerate. Those eggs will actually die. What we're trying to do in a stimulated cycle is to get multiple follicles that were recruited to grow and to produce mature eggs. So we're actually rescuing these eggs that would otherwise have been thrown away for that cycle. In an IUI cycle with Clomid or letrozole, we're trying to get maybe 2 or 3 eggs at a time instead of just one. In an IVF cycle, we ideally want to get all those follicles that are there at baseline to grow and to produce mature eggs. And so another important thing is that we're not reducing your egg count. We're not taking out eggs that you otherwise would have had available to you for the future. So this is showing that idea on ultrasound, what it looks like on ultrasound as we're, looking through your cycle. So these are the antral follicles, the small follicles that each contain one egg that we can see at the beginning of the cycle. And in an unstimulated cycle here, you can see that there's one follicle growing, and these other follicles are going to degenerate. In a stimulated cycle, there's multiple follicles here that are growing. And if we're doing IVF, let's say, we do an egg retrieval and we try to retrieve eggs from every single follicle. So we're, again, rescuing those eggs. Ovarian reserve testing is an important part of the workup for fertility treatment. And ovarian reserve refers to the number of eggs that you have left. So we can get a sense of whether you have a high egg count or a low egg count by doing this testing. The use of ovarian reserve testing is mostly to predict response to ovarian stimulation for IVF. So if someone is doing IVF or egg freezing, where we're giving those injection medications to stimulate the ovaries, if there's a higher ovarian reserve, we predict that we can most likely get a higher number of eggs in one cycle. It does not necessarily predict natural fertility or even success with Clomid or letrozole or IUI. The way that we test ovarian reserve is with AMH and antral follicle count. And these are the two main ways. So AMH is a hormone that's made by granulosa cells that are surrounding the follicle. And so the higher the AMH level, the more follicles, the more eggs that you have. The other count is an AFC, or antral follicle count. So the number of follicles that we can see at baseline correlates with the AMH level, correlates with the ovarian reserve. With IVF, because we're trying to get as many eggs as we can to grow, the number of follicles that the ovary has brought up for us at the beginning of that cycle represents, sort of the max number of eggs that we can get. And so with a higher follicle count, it's more eggs we can potentially get. In a natural cycle, or even with Clomid or letrozole, if you're ovulating 1 egg at a time or 2 eggs at a time, what really matters is the health and quality of those eggs. And that's related to your age. It's not related to the AMH level, and it doesn't matter how many extra follicles you have in your ovary. And so that's why the ovarian reserve testing really predicts response to stimulation as far as numbers, but not necessarily egg quality and not necessarily chances of getting pregnant. But it, again, is something that is going to potentially figure into a decision of whether to do IUI or IVF. Okay, so what are some of the things that you should consider? So we talked a little bit about age. If you're older, for example, that's definitely a factor. We'll go into these each in a little bit more detail. You want to think about what is your underlying diagnosis, what is, if there is a specific reason for the, infertility, or if it's unexplained and we don't know exactly what we're treating. How many kids do you want to have? Do you want to plan for the future? Are you going to be older when you get to your second or third kid and you want to make plans now to increase your chance of success of having the whole family that you want to have? And how long have you been trying? That's another factor too. Or have you not been trying? Did you just start? How long, do you think that you want to kind of be in this process? How quickly do you want to jump to something that has a higher chance of success, but maybe more invasive? And so what are the advantages of one versus the other? IUI is less involved. It's fewer visits, fewer medications, less invasive. You don't have, an invasive procedure under anesthesia, and it's less costly. So especially if if you don't have insurance coverage, for example, that can be a factor. IVF has a higher chance of success per cycle. There's a lower risk of multiple pregnancy, actually. So with IVF, especially when we're biopsying and testing embryos, we will almost always put in one healthy embryo into the uterus at a time. So it results in one baby. Now, there is about a 1 to 2% chance, actually, that the embryo can split and result in twins, but it's, more rare. With IUI, if we're giving Clomid or letrozole and getting multiple follicles to grow, there is a possibility that more than one of those eggs will be healthy and result in a pregnancy. And so you could end up with twins or triplets. Now, twins or triplets are a more risky pregnancy, more risky for the health of the babies and for the mom. And so it's not our goal. Our ideal is one single baby at a time. And then another benefit of IVF is that, ideally we're making multiple embryos in one cycle that are healthy. We biopsy them. We know which ones are the healthy embryos. And so you have those extra embryos available to you for multiple tries, and also for future children. So you can save those embryos for the future and then have a high chance of pregnancy when you're at an older age, when it may be harder to get pregnant using your eggs at that time. So let's talk a little bit about success rates, talk about the numbers. So now remember, we talked about the baseline fertility rate is about 20% per cycle. And that includes all comers, healthy young couples. So as you get older, it's like maybe 10 to 15%. Now, someone who has infertility, you've been trying for a year and it hasn't worked yet, the baseline is now lower. Maybe it's like 5 to 10%, depending on age. So for couples with unexplained infertility, for example, the success rate with Clomid or letrozole with IUI is about 10 to 15 per cycle. It increases your success rates by maybe a few percentage points. It's not going to be a huge chance of success per cycle. And that's because, again, we're really, with the medication, we're giving the eggs a little bit of a boost. With the IUI, we're giving the sperm a little bit of a boost, but everything really is happening internally, and we're not changing that much about the process. If you do multiple cycles, the chance that, overall one of those cycles will work goes up. So maybe 30% after 3 to 4 cycles that one of those cycles will have worked. After 3 or 4 cycles, the chance that it's going to work actually goes down. And so, often at that point, we may consider doing IVF. Now, in someone who is not ovulating, they're really just starting to get an egg in the game. And so by causing them to ovulate and do an IUI, we're really bringing them closer to the natural fertility rate. So the chance of success may be a little bit higher, maybe more like 15 to 20%. It may make sense to do more than 3 cycles in that case because they've essentially just started trying because they haven't been ovulating before we started the medication. With IVF, if we have a tested euploid embryo, euploid means chromosomally normal, that embryo has about a 75 to 80% chance of a positive pregnancy test at our center, and about a 50 to 60% chance of live birth, so healthy baby. So not every embryo works. Sometimes miscarriages do happen, but the success is much higher than even natural fertility, and the miscarriage rate is lower. And so with one embryo, and especially with 2 or 3 embryos, you have a very high chance of having at least one baby. So I'm going to talk through some diagnoses and how to think about which way to go. I'm just scrolling through the questions. A link will be recorded. That was one of the questions. Okay, so I'll come to these questions at the end. So let's go through some of these diagnoses. So male factor. Male factor means that there is abnormalities in the sperm counts or the sperm shape or the way the sperm are moving. So for mild male factor, meaning the counts are a little bit low, let's say, IUI can be helpful because we are getting a more concentrated sample of the best moving sperm and injecting it directly into the uterus. It's bypassing some of the barriers in the vagina and the cervix and bringing the sperm a little bit closer to the egg. But we still need good counts in order for IUI to work because the sperm still has to do the job of swimming through the tubes and finding the egg. So with very low counts for severe male factor, IVF is really the way to go with ICSI, which means intracytoplasmic sperm injection, which is what we were looking at in that picture where the needle injects one sperm into one egg, and that can really cure a lot of issues of severe male factor infertility, issues of fertilization also. Okay, so next one is tubal factor. So what if the tubes are blocked? Then really you need to do IVF because with blocked tubes, the egg is not going to make it into the uterus. And with IVF, we essentially bypass the tubes because we extract the eggs, fertilize them in the lab, make embryos in the lab, and then put the embryo back into the uterus through the cervix. What if you have one blocked tube? And that was one of the questions. So if you have one blocked tube, you still can get pregnant through your other tube. It can make sense to continue to try naturally. It can also make sense to try with IUI. You may want to think about using Clomid to try to increase the chance that you ovulate from both sides so that you ovulate from the side of the open tube. We know that the tube can actually pick up the egg from the other side, even if it ovulates on the opposite side, but also the blocked tube might pick up that egg and then the egg will get stuck. So there's probably a little bit lower chance of success with natural conception or with IUI if one tube is blocked, but you have the option. But in that case, I would say you may want to think about doing IVF, sort of sooner rather than later and not spend too much time trying with IUI because that blocked tube may decrease your chance of success. Also, if there's abnormalities in the tube, like a hydrosalpinx, which means fluid in the tube, that fluid can leak back into the uterus and actually be toxic to the embryo and decrease the chance of successful implantation. So in those cases with a severely damaged tube, we actually would recommend to remove the tube. And if you have one tube left, you can still get pregnant with, intercourse or IUI. But if both tubes need to be removed, then, removing the tubes and doing IVF is going to be the best way to go because if those tubes are damaged, they're not working anyway. What about diminished ovarian reserve? So very low AMH level, very low follicle count. So you can kind of think about this in 2 ways. One way is that IVF can help expedite treatment. It can help get you to pregnancy faster. And it also gives you the ability to save embryos for the future, for future children. So if you know that your reserve is already low now, by the time you get to your next baby in 2 to 3 years from now, your reserve is going to be even lower and you're going to have, and the egg quality is going to go down. You're going to have a lower chance of success. So you may want to try to make embryos now that you can save for future kids. The flip side is, let's say you want one child, or you just are focusing on this baby now. In an IVF cycle, if we can only get 1 or 2 eggs to grow, your chance of success may not be that much higher compared to IUI, where we get 1 or 2 eggs to ovulate. So that's something to think about with very low reserve, with, let's say, not a great response to IVF, where there's not many eggs growing. It sometimes may not be worth it to go through the whole egg retrieval and make embryos in the lab. And sometimes in those cases, we will recommend to try IUI instead. Polycystic ovary syndrome, or PCOS, is a condition where, in many cases, patients are not ovulating regularly. So for those patients, we'll often do letrozole for ovulation induction to get you to ovulate. And depending on, the other testing results, have intercourse or do IUI. But, IVF is still going to have a higher chance of success per cycle, and will also, again, give you the ability to make multiple embryos for multiple tries, or for, to build your full family. Advanced reproductive age. So what if someone is getting into the later 30s or 40s? So generally, IVF is going to be more strongly recommended in those cases, because the goal there is to find that normal embryo. So, right, let's say you're 41 or 42, and at this point, 60 to 70% of the eggs are going to be abnormal. It's most likely going to take a while to have success. If you do get pregnant, there's a pretty high chance of miscarriage. And so by doing IVF, we hopefully can get multiple eggs, make multiple embryos, find the normal embryo, and then put back that embryo and have a very high chance of having a healthy baby. IUI can also be a good option, where we can use Clomid, let's say, to try to get you to ovulate 2 or 3 eggs at a time, and that's going to increase the chance that one of those eggs is going to be healthy and normal. Unexplained infertility is where, you've been trying to get pregnant, it hasn't worked for a while, all the testing comes back normal, the sperm counts are normal, the tubes are open, you're ovulating regularly. This is very common. This is about 30 to 40% of cases of infertility that we see this. And, it could be that there's really nothing that's really wrong, and it's going to happen soon. It's just taking a little longer. Or it could be that there is something going on that we can't fully pick up on our testing. And so for unexplained infertility, typically we approach IUI as the first line treatment. We often will do 3 cycles of IUI, because, as we had talked about, after 3 cycles, the chance that it's going to work starts to go down. That being said, if someone's not ready for IVF or doesn't want to do IVF at that point, we definitely can do more IUI cycles. We have patients who've gotten pregnant on their 5th or 6th IUI. It happens. It's just, statistically, the chance is going to go down a little bit. And so IVF is really a way to expedite treatment. And then again, that idea of making multiple embryos. So it's never wrong to go straight to IVF because of those benefits, if that's something that you are interested in. So thank you very much for your attention. I'm going to start going through some of the questions. But before I do, I just want to say to feel free to reach out. You can email us. Our email is here. Call us to make an appointment. After the presentation, we will send out a recording, and we'll send you some more information about us. So please feel free to reach out, with any questions or anything. Okay, so going through some of the questions now. So it was about success rates for IUI versus IVF. We talked about that. Can Clomid cause fibroid regrowth? Probably not. Fibroids tend to generally grow over time. So if you are doing multiple cycles, it could just be the time factor that's causing the fibroids to grow. Most likely not the Clomid itself. There was a question about 1 blocked tube, so we talked about that. So question was odds of success after 3 rounds and whether to do more. So like I said, each cycle is about 10 to 15%, and then it goes down a little bit if it hasn't worked yet after 3 to 4 cycles. But it still could work. I think it's worth trying, especially, in this question, there was no insurance coverage for IVF. And so I think it is definitely worth trying some more IUIs and see what happens. And that's where age comes into play too. If you're younger, you have a little bit more time to try more IUIs before doing something more aggressive like IVF. If you're, let's say 40 or closer to 40, you may want to think about IVF sooner, because the longer you kind of wait, if you do end up doing IVF, in 6 months, you're going to have a lower chance of success at that point. So there's a question of ovulation strip over ultrasound to determine the trigger shot. So the ovulation strips can work, but they're not so reliable for everybody. And it also is not always super accurate if you're going to ovulate like today or tomorrow. If you're timing intercourse, that's really fine. Intercourse honestly doesn't need to be timed exactly to the day that you ovulate. You really want to be having intercourse, starting a few days before ovulation, every other day or so to get the sperm on board. But for IUI, because it's a one-time thing, we want to know more precisely when you're ovulating. So I do recommend doing a follicle scan. Another reason to do a follicle scan is, especially if you're taking medication like Clomid or Letrozole, we want to make sure that we don't have like 5 or 6 follicles growing and you're going to end up with like triplets or quadruplets, right? So the scan can be important for that too. For, let's say, a natural cycle IUI where we're just following your natural ovulation, that's less of a concern. We can tell the sex of the embryos when we do the embryo biopsy with pre-implantation genetic testing. When we test the chromosomes, we know whether it's XX or XY, so we know the sex, and you do have the option to choose the sex of the embryo that you implant. We can't guarantee that you're going to get the sex that you want, right? Especially if the reserve is lower, you may only get one normal embryo, and it may not be the sex that is the one that you want. But if you have, let's say, multiple embryos to choose from, you definitely can select your preference. So there's a question about being charged for IVF. If the first cycle, so you're charged per cycle of IVF. Many insurances do cover IVF, not all, unfortunately. And so the charge is not based on the number of embryos that are made. So it's one charge if it results in, 5 embryos or 0 embryos. There's a question about location. I'm located in New York City. Our office is on Madison Avenue between 59th and 60th. That's the location that I'm based at, and that's where our lab is and where our procedures are. We also have locations where we see patients on, on the West Side and in Soho. And then we also have a lab in Brooklyn, in Westchester, and in Long Island. So we are all over the New York area. And so you can definitely, call or email if you want to see me or, any of the other doctors. How soon after open myomectomy can you start the IUI process? So after an open myomectomy, it's typically recommended to wait 3 months before trying to get pregnant. So that's what I would recommend usually is three months. For IVF, if you would like to have twins, would it cost more? It would not necessarily cost more. We typically will only put one healthy embryo in at a time. With IVF, we're really trying to avoid twins because twins is a riskier pregnancy. Twins are typically born premature, lower birth weight. There's a lot of negative outcomes that can happen for the babies. And so our goal is to create one healthy pregnancy at a time. So cost of IVF and IUI, I would refer you to our finance team to get specifics on this if you're a patient at RMA or wherever you're a patient at. But just sort of general ballpark, IVF is more than IUI. Typically IUI will cost maybe on the order of somewhere between 1,000 roughly. IVF can be, couple 10, 20,000, something like that. And now that's if it's fully out of pocket. So in New York State, there is an insurance mandate where large group insurances actually have to cover IVF, but not all insurances fall under that mandate. And so there are some exceptions. A lot of employers have good fertility benefits that will cover IVF and even fertility preservation. I would say if you don't have insurance coverage, talk to your job, talk to your insurance. Is something to kind of investigate more. At RMA, we take almost any insurance. And so if the insurance covers IVF, it should be covered here. Frozen eggs, to use an embryo. So frozen eggs is a way to preserve fertility, and they can be stored indefinitely. And when you freeze eggs, the process is really the same as the IVF process with the injections over the course of a week and a half, the egg retrieval. The difference is that the day of the egg retrieval, we retrieve any mature eggs or we freeze any mature eggs that are retrieved. And then in the future, when you're ready to use those eggs, we thaw the eggs, fertilize them with sperm, make embryos in the lab, and continue the process from there. So it's all the same process. It's a question of where you're pausing and freezing. And then we can still freeze embryos at the embryo stage to test them, even when they're coming from frozen eggs. Frozen embryos can be stored indefinitely also. So someone who's trying to get pregnant now will typically, for example, make the embryos, they get frozen so they can be tested. There's also benefits to doing a frozen embryo transfer as opposed to fresh. And so in, let's say, the next menstrual cycle, you'll prep for a frozen embryo transfer, thaw the embryo and put it in. You can also thaw the embryo in 2 years, 5 years, 10 years from now, and the chance of success is really going to be the same if that's a tested chromosomally normal embryo. If you're trying naturally, how many days after your period starts should you have intercourse? So that depends on your cycle length. And this is an important thing to consider if you're trying. Your period comes 2 weeks after ovulation. That's pretty consistent. So from ovulation to your period is 2 weeks. The time from your period to your next ovulation is more variable. So if your cycle length varies, let's say, it's 24 days from day one of one period to day one of next period versus 30 days from day one of one period to day one of the next period, the time that's varying is the time from your period to your next ovulation. So you don't necessarily know when is the next time you're going to ovulate, but you can predict it based on your prior cycle length if you have regular cycles. So if you have 28-day cycles, you typically ovulate on day 14. So you're most likely going to ovulate on day 14. I'd recommend to start having intercourse around day 10, just in case you ovulate a little earlier. And you can use the ovulation prediction kits to help kind of confirm when you're ovulating. If your cycles are more variable, or if your cycles are longer, that means you ovulate later. If your cycles are shorter, that means you ovulate earlier, and you may want to start having intercourse earlier on in the cycle. There's another question about finances. I think we basically addressed that. If you have questions about how far your insurance is going to go, if it will cover one cycle or more, and whether it's worthwhile, that has a lot to do with the ovarian reserve and age. And so definitely something to talk about with your doctor. What is your likelihood of success with one cycle? What are the chances that you're going to need more than one cycle? And I'm going to stop my screen share just so you can see more of my face. Okay, so what is the best or perfect size for the egg for IUI? So when the follicle is 18 millimeters or more, it's typically should have a mature egg and be ready to ovulate. There's no one ideal size. When we are doing ultrasound, we're really looking for the follicle to be 18 millimeters or more. Over 20 is also good. There's no sort of upper limit, generally speaking. Once it's over like 30 millimeters, it may actually be more of a cyst than a true follicle, but usually when we do the trigger shot, it's somewhere between 18 and 25 millimeters. An egg that's 16 or 17 millimeters at the time of the trigger also has a very high chance of being mature. And when we're doing IVF, for example, usually not all the follicles are going to be the same size. If it's 14 or 15, it has a high chance of being mature. The ones that are like 12 or 13 might be mature, but it's a little bit lower chance, but we'll retrieve everything we can and see if it gives us a mature egg. So there's a question about egg freezing. Egg freezing is, it's not perfect, right? It has some limitations. And, I always tell all my patients that there's no guarantees with egg freezing. Not every egg survives being thawed. Not every egg fertilizes normally and grows into a healthy, high quality embryo and has the ability to implant and result in a healthy pregnancy. A lot of that is just part of that inefficiency of human biology that we talked about, and we see it really play out in the lab when we retrieve eggs for IVF or egg freezing, but with egg freezing, there's the extra component of how many eggs will survive the thaw. On average, thaw rates can be maybe like 70 to 80%. At RMA, our rates are very high, often, upwards of 90%. So egg freezing is a really great way to preserve fertility and give yourself a backup option for the future, but it, again, is not a guarantee. But the more eggs you can freeze at a younger age, the better your chances of success. So let's say, this question says they froze their eggs in 2018, and there's some concern about whether those eggs are going to work. I would say if you are trying to get pregnant and you're thinking about using frozen eggs, you might want to think about doing new fertility treatments now, let's say with IUI or even an IVF cycle, especially if you want to have multiple kids, and save those eggs for the future. If you want to have one kid, or maybe you have a kid and this is going to be for your, you think is going to be your last kid, then by all means go ahead and thaw the eggs, see what happens, see if it gives you something. But we often do recommend, because we don't know how the eggs are going to do, to kind of save those eggs as a little bit of, more of a last resort. And if you're still, let's say, in your late 30s, you could try an IVF cycle now and, again, save those eggs. And some of that is going to depend on insurance coverage, and how many more kids you want to have. For same-sex couples using a donor, how many vials should we buy for IUI? This is a really good question, and it's a really hard question to answer. So when you think about those success rates, for a same-sex couple using a donor, if you haven't tried anything yet, this is your first time trying, using a donor should put you closer to that general success rate of about maybe 15 to 20% per cycle, depending on your age. If you're getting into the later 30s or 40s, it's going to be lower. You're probably going to need a few cycles to have success. One thing to think about is if you want to have multiple children with that donor, if maybe you each want to have a child with that same donor, you're going to want to get extra sperm. And so, I think for IUIs, you'd probably want to have at least 3 vials, maybe 6. Each IUI is 1 vial. With IVF, each IVF cycle is 1 vial, and that IVF cycle can potentially make multiple embryos, which can give you, multiple tries and multiple children. So you're not going to need as many vials if you're going the IVF route. Again, that is going to depend on your ovarian reserve, your response to stimulation, how many embryos you can make. But those are some of the things to think about. So after the IUI, how long should the patient lay down? So we typically will have patients rest for about 5 to 10 minutes after the IUI. It's not really based on anything. It gives you a chance to kind of relax. After that, normal activity is fine. There's no restrictions on activity. And it's probably not really necessary to lie down for that 5 to 10 minutes. We do it as sort of a precaution. And, so that's what we recommend. But again, it's not super, based on anything that has said that that's clearly going to increase your chances. It's not like mandatory, and you definitely no benefit to lying down for more than that, like 5 to 10 minutes. So there's a question related to age. So the question is, if someone is 50 years old, still getting periods, is there a chance of getting pregnant? And so if we look back at that slide, this one. So, you can see this is the proportion of embryos that are abnormal. By 44 to 45, it's about 90% abnormal. Past age 45, there's basically no embryos that have come back as normal. Now, we will still, if someone really wants to at age 46 or so, try an IVF cycle. You never know. It has happened. We will help you if you really want to try, with an understanding that there's a very low chance. By 50, so even if you're getting periods, that means that you do still have some eggs left, but it's essentially 100% of the eggs are going to be abnormal. So there's unfortunately almost no chance that it's going to work with your own eggs. Using an egg donor, we can create a healthy embryo and have a very high chance of success using that embryo. And we can create a pregnancy past 50, even if you're not having periods anymore, by giving hormone supplementation, and be able to create a pregnancy using a healthy embryo. How many days can you test for pregnancy after an IUI? So it's 14 days, give or take, after the IUI that the pregnancy test will come back positive. It correlates with the same, if you're trying on your own and when you ovulated, you would want to take your pregnancy test 2 weeks later. You basically will either have a positive pregnancy test, hopefully. If it's negative, you'll get a period, and then we can start over, with the next cycle. So that's all the questions I see in the Q&A. I'm going to stay and hang out for a little bit to see if any more questions come in. Thank you, everyone, for your attention, for being here. And do feel free to reach out with any additional questions. We, again, will be sending you that information after the talk. Do we have social workers on staff? Yes, we do. We actually have 2 social workers on staff that are available to patients to meet with and talk through as you go through treatment. It's a very stressful and emotional and taxing process. So we have that as a resource available to our patients. We also have a nutritionist on staff to help with making sure that your nutrition is optimized. For some patients, weight loss is a goal, and so they will often work with our nutritionist to help with those things. I'll just wait a couple more minutes to see if anyone has any more questions. All right, thanks so much, everyone, for coming. And again, like I said, please feel free to reach out. The email is info@rmaofny.com, and we will be sending you the information. Hope everyone has a good rest of the evening. Take care.